Hi, my name is Juliet, and I am the creator and host of Connecting the Dots podcast. I love ideas and problem solving, and my career in communications has led me down a path of curiosity. Why we do what we do, how we tell better stories, and how African scientists solve everyday problems. Join me on this enlightening and entertaining exploration of African science like you've never experienced before. Get ready to laugh, learn, and be inspired. So Professor Faith Osier is a pediatrician, scientist, strategist, educator, and expert communicator with research groups based at the Kenya Medical Research Institute, Imperial-Wellcome in Kilifi, and at the Heidelberg University Hospital in Germany. Her work focuses on developing a malaria vaccine. Between 2019 and 2022, Faith Osier served as the president of the International Union on Immunological Societies, the first woman, African woman, to occupy this position. She currently serves as a co-director of the Institute of Infection at the prestigious Imperial College, London, which I also would like to say happens to be where I received my training. So, karibu sana, Faith.
Thank you.
So Faith, we just quickly walk us through your background in pediatrics and, with your first internship being at the coast of Kenya in Kilifi. Just looking back, is this what got you interested in working on the malaria vaccine? And maybe we can also look back at your personal and professional background leading up to, your focus on developing a malaria vaccine. Go ahead, Faith.
Thank you. Thank you so much, Juliet. Thank you for hosting me. I have to just say that my research groups are now based at Imperial College, and Heidelberg was in the past.
Yeah.
Just for clarity. But, my journey, I trained in the University of Nairobi, and I have to say I was as green as anything. I just knew that I needed to finish medical school. Before that, I thought, one day I'm going to be somebody who finds cures. I'm going to be a doctor like friends of my mom that I used to see, and I'd find cures for things like HIV, just sort of vague childhood thoughts. But by the time I got to med school was pretty hard, and it was about surviving and coming out alive on the other end. And then it just happened that my big brother was working in Kenya breweries at the time, and he was posted in Mombasa.
Yeah.
And so I said, hey, I'm Nairobian, I'm going to go to Mombasa, and I'm going to be walking on the beach every day and doing all these romantic things. And that's how I ended up at Coast General Hospital doing my internship. Mm-hmm. It turned out that my brother was posted out as soon as I arrived in. But in any case, I did my internship there. While I did my internship, I was really set on being a surgeon.
Oh.
But at that time, we had tribal clashes, some kind of clashes in Kenya. And I was an intern in surgery at that exact time. And I dealt with so much trauma and so much blood that the dream of surgery just dwindled and died.
Yeah.
But what I found is that I really enjoyed pediatrics, which was a bit strange. I wasn't really attached to children or anything, but I really enjoyed it. And that's how I then, after completing internship, went to work in pediatrics in Kemri, Kilifi. Mm-hmm. And that's where I encountered malaria, and I encountered the malaria researchers. And that's how the malaria journey began. Yeah.
Just on malaria 101, there are mosquitoes everywhere. Why is it that the ones in Africa seem to be the deadliest? And how come adults don't die from malaria as much as children do? By the time you transition from Mombasa to Kilifi, still at the Kenyan coast, I assume being a pediatrician, you'd have been looking at a lot of cases of malaria presenting in younger children. So why does it feel like the mosquitoes are against us here in Africa?
No, I think the mosquitoes are enjoying life as much as we humans do. Yeah. In this climate, the tropical climate, it's very good for the mosquito, and the mosquito thrives just as we love the sun and we thrive. What the mosquito transmits is a parasite that causes malaria. But the remarkable thing which amazes me and which you've just mentioned is that this is a big problem in children, but this malaria is not the same everywhere. So in Nairobi, you might find, because people don't experience malaria that frequently, that it's present in people of all ages. People of all ages are getting sick with malaria.
Okay.
But in a place like Kilifi, when I went to work there for the first time, it's what we call an area of intense transmission. So just imagine a lot of mosquitoes biting people a lot of the time, every day, all year round. So when the conditions are that intense, that's when we see the pattern that children are the ones getting sick, but adults, after getting so many infections, their body learns how to do something that stops them from getting sick. And so that's completely correct. When I went to Kilifi, on the pediatric ward, it was choker full with children, 4, 6 on a bed with malaria, with severe malaria. But if you went to the adult ward, you wouldn't find adults in there with malaria. And so that's the kind of mystery, right? That in the same house, the child is sick and dying.
Yeah.
But mom and dad and maybe teenagers and older guys in the home, they're completely fine. Both of them have the parasite, right?
Yeah.
But the older person has learned how to keep the parasite in check. And the younger person has not yet learned that. And that's why they get deadly sick. And so all these years, what we've been trying to understand is what's going on in the older person that we can take out and give to the younger person so that they can do the same magic and control that infection. And that's what the malaria vaccine and the vaccinology is really all about.
So for you, what was it that inspired you to move away from the hospital setting to now establish, lab groups, and then not only at the Kenyan coast, you went to Europe, to Germany, and now, as we've heard at the very beginning, you transitioned to the UK. What was that transition like, and what has been the lessons that you've learned in just developing a research group, and as an African woman based in Europe as well? Interesting.
So it's been a journey. When I started out, I couldn't see the whole distance. And in fact, I think we see more as we grow. So I certainly wasn't seeing the whole distance when I started. All I knew was I didn't want to be a statistic. I was in Kenya High, I think you might have been there too.
Yeah.
And the interesting thing that used to happen in Kenya High is that when you left, your name got written on a board that was hanging somewhere in the schools. I don't know if it was in the dining room, but there used to be boards that showed all the people who graduated here in 1920, 30, 40. So my name was added in 1989. And
yeah.
and I just thought, when I started to do my PhD, I just don't want to be another statistic. Yeah, my name is there. Faith was here. She did a PhD, and that's it.
And that's
I
it.
really wanted
Done.
to
Done, dusted.
have a bit more. Yeah, have a bit of an impact. Yeah. So the journey has been one of growth, steady growth. I started in a small way. I was first I did a master's project. Coming from being a doctor to going to the lab was hugely exciting. From my master's project, I stayed on the same track. And I think that's perhaps one of the messages is I actually just stayed on the same track. So I was just growing, but within the same track. So I started with studying responses to one antigen from the parasite for my master's. For my PhD, I moved on to 6 antigens. As I became a postdoc, that went up to 36 antigens.
Yeah.
And then by the time I was going to Heidelberg, we were making a chip with more than 100 antigens.
Yeah.
So I've just grown in terms of what I've been trying to learn about the immune response. And then the team, because in the end, The second big message is teamwork.
Mm-hmm.
You cannot do all the things that you want to do by yourself. And one thing that was really great at Kemri was we had the whole system of having interns and young people coming from attachment. And these people, some of them are still in my group now, but they become your extensions. They become the team that helps you do so much more than you can do by yourself. And they become the team that come up with even better ideas than you yourself, right? So they've been of much value to me as I have been to them. So what I can give them is progress in their careers, a sense of direction, guidance. But what they've given me, I can't measure in terms of what we've been able to achieve as a team. So it's just been a story of growth. Moving abroad has been about funding, and the funding landscape had been pretty limited in Africa, and it still continues to be so. And so I took the opportunity when it came to I had funding from the Alexander von Humboldt Foundation. And when that came to an end, I found myself in England, and now I'm a professor in England. That was never on my radar, like, hey, I want to be a professor at Imperial. That was just never there. I was really just following my heart, which was, let's understand, we've got a real good model for how you can control malaria. Let's try and make that model work through vaccines. So that's really what I've been trying to do.
And very impressive, given your research group is very international. I'm assuming as you transition to Europe and now to the UK, you must be having teams that disciplinary, multi-international. One thing we are interested in is the vaccine development process. Can you just walk us through and maybe also unpack when you talk about antigen? You've gone from 1 to 3 to 100 and using the chip. Just tell us what is an antigen, and then when a scientist discovers, something in the lab, how does that go to, say, big pharma, so that it ends up on that child you used to treat, immediately after you graduated or moved from the University of Nairobi as a pediatrician?
Yeah, so if I can step back, really, for me, the vaccine development starts with the observation of the disease.
Mm-hmm.
So learning where is the disease, in what group of the population is it, what's the natural history of the disease. So it's basically learning what is the disease, what causes it, what's the life cycle. So that's the epidemiology, the clinical features, the cell biology. So you got to begin with a good, solid understanding of those things. And that's why I feel that my time in Kilifi was really invaluable, because that's where we learned. We saw firsthand, where is malaria? Who is it affecting? When does it become serious? So you learned all those things. And then you couple that with understanding the biology, what causes it. And so we learned that it was caused by a parasite. And the parasite, I talked about antigens. So the proteins, these are just the proteins that make up the parasite.
Mm-hmm.
So we're all made up of lots of different proteins. And in the parasite, there's over 5,000 of these proteins. And so it's trying to say, okay, we know that the immune system, my immune system, your immune system, we generate antibodies, and these antibodies are specific, like a lock and key. They only bind to certain proteins, so from the parasite. So when I talk about an antigen, I'm talking about an individual protein on the parasite to which the immune system in the human can see that, hey, there's a bad guy in here. And that seeing is through the antibody that's very specific to that protein. And so the problem for malaria vaccines is that, unlike a virus that, for example, COVID, it's got about 30 proteins. So one can quickly work out which is the likely protein that the immune system is going to see.
Mm-hmm.
But when you've got malaria, it's got like over 5,000 proteins. And these proteins are changing all the time. So when it's in your liver, it's different. Before it gets to your liver, it's different. When it's in your blood, it's different. So you've got a complicated set of antigens, of proteins that you're trying to work out which one or which group is really important for the immune response that I would like to see. And so that's pretty much what I've been trying to understand. And that's why I've been trying to say, okay, there are over 5,000 proteins. How can I rationally attack this problem? How can I prioritize that number down to something that I can test? And so that's what we've been doing gradually and gradually and gradually. Yeah.
Okay.
And so the process is, once you think you've got it, right?
Yeah.
You try and build up as much evidence. So for example, we've been studying saying, okay, once an antibody binds, then what happens? How does that binding actually lead to you getting rid of your malaria or whatever infection that you have? And so then we study the mechanism. What's, physically, how's that key turning in the lock?
Yes.
And how's that thing being broken apart? So you try and get a little bit more evidence. And then the next thing you would do is say, okay, I think I know which is the protein. I think I know exactly how it's working. Then you do a test in an animal model. So usually you get like a mouse model. This becomes complicated because mice are not the natural hosts for malaria. Yes. So people do different things to try and make it work.
I don't think I've ever heard mice getting malaria.
Yeah. So, but you try and get some, proof so that when you approach a company and say, hey, I think I know what I've got it. You want to tell them, I know what protein it is. I know the mechanism. I know how the key turns in the lock. Yeah. And here's my demonstration that it works in a kind of animal model. And then that's when industry begins to get interested and can pick up the thing. From there, you go and test it perhaps in what we call non-human primates. So a mammal that's very similar to us. And there's some that like certain types of monkeys. Okay. Primates. So you can infect them with malaria, actually, like the same one we have in humans. And then you can see whether you're creating the antibody response that you want, and then, yes, if that's all looking good, then you have enough data to go into human clinical trials. And then if that also works, then, you can roll out your vaccine. Yeah.
We are very familiar with the RTSS vaccine, and I think you were also involved in that particular research. Can you talk briefly about the RTSS vaccine and then its subsequent rollout in Kenya, Ghana, and Malawi? And then maybe you can conclude on the recent good news, I think it was coming from Cameroon, about the malaria vaccine, if those are the same thing or that's also a new vaccine. Meaning that I think, Faith, you might be out of a job soon once we discover a vaccine for malaria. Doesn't that mean the disease will then cease to be? But you can enlighten us a little bit on that.
I would love that I was out of a job because there's so much disease still in the world. So unfortunately, I'm not yet out of a job. So we're really excited about there are 2 new malaria vaccines that have been licensed within 2 years of each other. And I'm just going to talk about them in the same breath because they're really similar. They target the same protein. So we talked about, so many proteins, which one is it? Okay. They actually target the same protein, okay, in the same stage of the infection. Okay. And I think that they're great, but they are not. The vaccines have several limitations still. Yeah, so it's a step forward and a good step forward, and lives will be saved. But the efficacy of the vaccine, if you think back to COVID, we were talking about vaccines of 90, 95, 99% efficacy. With these malaria vaccines, the efficacy is lower and it's variable. So in some places, it can be as low as 30%. And in some places, it can go up to 75%. depending on a whole bunch of factors. So the efficacy is not where we want it, and there's room to improve. Secondly, is the duration of protection. So once you get the jab, for how long will you stay free of malaria? And again, I use the analogy of the COVID vaccine. In the countries in the West, in the height of the pandemic, people were getting those shots every 6 months. Why? Because the protection wanes, gradually weakens after some time. And that's exactly the same situation we have with malaria. With the current vaccines, one, we have to give 4 or 5 doses. And then, the studies are still ongoing for how long that protection lasts. And we know that it's generally 6 months, possibly to a year. So that still means that people will need to keep on getting shots. And the infrastructure for giving people these shots, it's really challenging to implement, right? So then there are still challenges. Then there was also a challenge which has been mostly overcome, which was of vaccine supply. And I think it's just important because this is a great area, an area I'm really interested in. And with the first vaccine, there were challenges of who's going to make it, and who's going to pay for it. And in Africa, we were not the ones making these decisions. These decisions are being made elsewhere by others. So we started with implementation, but since then, there've been more vaccine that's been available. There's now a second vaccine for which we are assured it's really going to be available, being made in India. But it begs the question, when will Africa make its own vaccines? Because when push comes to shove and a country is in crisis, that country will focus on its national situation before it turns to think about helping dear old Africa. And so Africa must develop the capacity to develop its own vaccines, and ensure its own health security within the continent. And that's something that I'm really passionate about, and my work is moving more in that direction now.
What are the top 3 things you would say, really briefly, and just looking at the clock there, what are the top 3 things you would want to mention on vaccine manufacturing on the continent? What needs to be, to be pushed forward or to be addressed? Infrastructure, maybe, capacity, I don't know. What would you say?
So I think that Rome was not built in a day, right?
Indeed, it wasn't. Yeah.
Whilst this is an aspiration that we just need to be, we just need to have our intention and hold on to it, because vaccine manufacturing is a complicated process. We have lots of infrastructure challenges. We have challenges with supply chains. We have challenges with the way the basic ingredients that go into vaccines, where are those sourced? How do they get into the continent? Can they be made on the continent? We have challenges with personnel. We have challenges with know-how. So, when you look at it, it looks like a mountain, really, that needs to be scaled. But I think that we've got to stay focused. We've got to keep our intent. And it's going to be a long road, but it's a road that we must take.
Okay. Well, we need people like you in the business to be able to address this particular issue of vaccine manufacturing over and above the research work that you've been able to do, and with different people. As we're concluding, what keeps you going and what does the future look like for you? I heard that you want to transition into vaccine manufacturing. Are you going to join the African Union? I think it's the AMA Institute. Are we going to see you become a Secretary General somewhere there, or the director there?
Well, I think the future is bright. My focus right now is on small scale manufacturing. I'm finding partners within the continent who have the heart and who have the vision and who are starting small. Yeah. So, because, when you take on a new endeavor, I think that there's value in beginning small and learning all the bottlenecks while you're still small, and learning your ecosystem that you need to survive, and then growing from there. So I'm really working at the grassroots end with manufacturers who are not known to anybody. They're just coming up.
Oh, wow.
But I think that this is really these are the people that we need to nurture and build our capacity so that we have more options rather than just a few big players who dominate the whole show. I think that we need to give the small players room to grow. And then we need to build the capacity and the infrastructure that allows it to become sustainable. So again, I think it's a journey, but it's the steps that we must take.
Okay, so there's an African saying that, and I think you would subscribe to this: you never climb a tree from the top. So it sounds like from what you're saying, you start small, you engage the small players, and we work together to be able to arrive at the solution, which hopefully is vaccine development on the continent. In a recent podcast, we hosted one great drug discoverer, Professor Colin Masimrembwa. And one of the things that surprised us was, in terms of drugs, vaccine, diagnostics, these tend to be imported into the continent. Do you think that Africa can be like India and China in the next decade, perhaps?
Yes, I think so. It's hard to put a time and say it's going to take a decade, but I think that we must aspire to do so. And I really think that health is a human right. It's a basic human right, and that there's so much potential to achieve so much in Africa if we give people that basic human right. And vaccines is one way to get there. To enable that. Putting a timeline on it, I think, is neither here nor there. There's a lot of hard work to be done on the way. But I think we definitely can. And and what I see happening is things coming together that are enabling us to do this. So I think it will happen. We can check in on the timelines in a few years' time. Yeah.
So, I mean, in terms of time, right now we are running out of time. So in a minute, Faith, what excites you, what scares you, and then who are two researchers or scientists who inspire you, African scientists who inspire you, in a minute?
Okay, I'm excited by the potential that's inside every one of us to be a powerful force for good, to make the world, to leave the world better than we found it. And while I work in health, you might work in communication, but we all have a role to play. And that's what really excites me, that when we discover what our role is in the big picture, then we're powerful forces for good. I'm not afraid of anything. I think one should follow their heart and go forward. And my heroes are Naledi Pandor from South Africa and Professor Suleiman Boop from Senegal.
Amazing examples. Thank you for giving your life to this critical area of infectious disease, which is malaria. We are very excited for you. We wish you well, and we're looking into what you will bring to the world and especially the continent. Thank you so much for your time, Faith.
Thank you, Juliet. It was a pleasure chatting this morning. Thank you.
Thank you. Thanks for tuning in to Connecting the Dots podcast, created by me, Juliet. This episode was brought to life by Mumbua and Kevin at Silent Global in Nairobi, Kenya. If you enjoyed this episode, don't just keep it to yourself. Share it, tag us, and let's keep the conversations going. Do let us know if there's any science topic that you'd want to hear about. And then join me on the next episode as I interview the next amazing African scientist here on Connecting the Dots podcast. Thank you.